professor of medicine at the University of Minnesota. She actually trained here. She did her medical students here. She went through her residency, her fellowship, and now staff. She's one of 3 surgeons that we have. She's the most popular one because she brings her dog in to do her weekend rounds. So, Matt, I think we should introduce pet therapy along with all your other things because her dog makes every patient smile. So she used to tell me that one of the first surgeries that she ever assisted on was a total pancreatectomy as a medical student with Dr. David Sutherland. And I think you all know he was the father of islet cell transplantation. So I think she is more than adequately qualified to speak to us on our next subject, surgical management of chronic pancreatitis. Dr. Varvara Kirchner.
Thank you very much. It was actually the first surgery, and I've never seen appendectomy when I was a medical student, but I've seen a lot of total pancreatectomies. Let's see. Uh-oh, that's right. You have to switch. Over to the screen instead. There you got it. All right. So I'll talk about surgical management. However, I felt like you can't just talk about surgery without really introducing the subject and talking about what happens after the surgery. So we'll discuss, I'll introduce quickly the concept of pancreatitis, which everybody I think knows here already about, and goals of treatment, as well as surgical options and post-operative management and outcomes. So, chronic pancreatitis with a benign is a benign inflammatory condition, as pretty much everybody knows here, but associated with unbearable pain usually, and as well as loss of the exocrine function and at some point an endocrine function. However, in addition to that, there are other complications that can be associated with it, associated with obstructions, either it's bowel obstructions, biliary obstructions. In very severe cases, you can have complications that involve the vascular structures, as well as with acute attacks, patients can actually develop multi-organ failures. In the worst scenario, actually, the mortality can happen from this disease. So it's not only pain, although pain probably is one of the most traumatic events that's going on constantly with these patients. So worldwide, the incidence of pancreatitis vary. They're been higher reported in Asia. The underlying causes in Western world, although over half of them is associated with alcohol, but there is still a very great deal actually associated with other underlying conditions. Has been discussed genetic as well as ductal obstructions, trauma, stones, autoimmune idiopathic. That's just to say a few. And it's definitely not the full list. The diagnosis is really multifactorial based on patient history, symptoms, as well as sometimes appropriate laboratory findings, however, not always going to be elevated pancreatic enzymes. We do perform genetic testing in the appropriate situations, as well as the imaging, including CT, MRI, EUS, as Dr. Freeman mentioned. So the treatment, I know that we all copied the slides from the same A student, so you guys already have seen those. The treatment, it centers around the treatment of the pain from chronic pancreatitis, which is multifactorial. It's associated with intraductal obstruction, pressure, as well as the inflammation and around the sensory nerves, and eventually central sensitization, which is a lot more difficult to treat if that progresses, as well as trying to decrease the long-term narcotic use in our patients and preserve islet cell function by reducing the chronic inflammation, minimizing the GI as well as malnutrition complications, and improve our patients' quality of life. So, of course, medical management or endoscopic management is what we're moving towards first. However, if the ongoing inflammation persists and the attacks persist and that fails, we have to talk about the surgery. And the type of surgeries we perform for the patients depends on their underlying condition, as well as also how well they can undergo a big major surgery. At the same time, what is going to be their success of the surgery, the location of the inflammatory condition within the pancreas, whether or not it's a diffuse or whether or not it's localized to one specific site, and also the anatomical features of the pancreatic duct, as you can see here. So there are multiple surgeries that have been described in the literature. However, the reality, you can be simplified. There is there is drainage plus some resection and versus resection alone. So the drainage procedures, as been mentioned about the Post-op, is an example of that. It's usually appropriate for type of the pancreatic disease where the duct is really dilated, so the minimum is usually 7 millimeters, and where actually the duct is being filleted open and the loop of bowel is connected to the pancreatic duct in order to release the pressure and drain the pancreas. So something that's been described previously in treatment of the pancreatitis from alcoholic disease, which is described as a chain of lake and dilated ducts. Kind of part of a resection and a drainage is an example of a Fry procedure. Dr. Freeman again mentioned this before. Pancreatic disease with extensive, he showed pictures of the pancreas full of stones, and at the same time you still have to have quite a big duct in order to perform the procedure. So part of the head of the pancreas is being resected. It's not fully resected, and the a loop of bowel again connected to the entire length of the pancreas. Other options is the partial resection of the pancreas alone without drainage. That would be appropriate more for the pancreatitis, which is localized to one part of the organ, either head, that would be a Whipple procedure, or a little bit less of a procedure, which is Berger, or distal pancreatectomy. In general, distal pancreatectomy would be associated with the fewer surgical complications. Whipple is more complex because pancreas in the head shares the same blood supply with the small bowel. Therefore, again, part of the small bowel is being resected, and the reconstruction becomes a lot more complicated. Depending on how much pancreas, in partial pancreatectomy is depending on how much pancreas is being resected, what is going to be expected islet yield, as well as what's going to be the endocrine function of that patient. We could isolate islets from the resected portion and give it back to the patient. So this is one of the options. It doesn't necessarily have to be total pancreatectomy. Historically, conventional surgery, fairly effective for a selected subgroup of patients. However, they will fail in 20 to 50% of patients, depending on the etiology. It's not suitable for the disease of small duct and with chronic pancreatitis. And also, again, as been mentioned before, if the patient is suitable for total pancreatectomy and you expect that their disease is going to progress, especially with the underlying genetic disease, we would recommend doing a total pancreatectomy. Also, the conventional surgeries, pre-existing surgeries, will eventually impair the islet yield for the future, and this is a consideration. So ultimate resection is total pancreatectomy and islet autotransplant. It has significant morbidity. It's not without complications. There is a high lifetime risk of diabetes, and there is a permanent need for pancreatic exocrine therapy. So initially, the first total pancreatectomy and auto-islet transplant was performed at University of Minnesota in 1977 by Dr. David Sutherland and Dr. Nigerian. Truly, this was almost like an intermediate step for them to learn how they can improve the allo-islet transplantation, which means taking the islets from a donor and giving them to patients with diabetes type 1, rather than doing the auto-islet. However, over time, this procedure became very acceptable for treatment of the chronic pancreatitis. And initially, although it was a surgeon-driven, University of Minnesota became a really multidisciplinary team where total pancreatectomy is offered as one of the options. However, we treat the entire patient and all the conditions rather than just a single procedure. So currently, the consensus statement is that primary indication for total pancreatectomy is the treatment of intractable pain with impaired quality of life due to chronic pancreatitis or recurrent acute pancreatitis when medical, endoscopic, or prior surgical therapy have failed. So Dr. Freeman already showed Minnesota paradigm. In fact, you expanded it further, medical and endoscopic therapy, and then if that fails, a surgical resection. For the diffuse disease, total pancreatectomy is what's recommended. We try to avoid drainage operations, again, because of the suboptimal outcomes. However, if patients are not qualified to undergo total pancreatectomy, we do consider those. So we've performed over 700 cases, and I'm sure Dr. Bellin has a more updated information on this. We discussed the indications. We did make sure that the patients do not have no other causes of abdominal pain, and the fact that they're able to manage the post-operative course because it can be quite complex. We're quite careful about identifying the diagnosis of the pancreatitis. These are our criteria for patients with chronic pancreatitis. It's chronic pain lasting over 6 months with morphological evidence as indicated by CT, endoscopic ultrasound, or several modalities together. The acute relapsing pancreatitis and hereditary pancreatitis are other two indications for the same operation. So in terms of operation, again, Dr. Schnarkotler and I steal the same slides from the same person. It is more complex than it can be thought of. Again, pancreas shares the blood supply with the duodenum, with the spleen, and we also take out gallbladder at the same time. If you look in the past literature, and that's I always warn patients, you'll see there can be reports of the spleen preserving total pancreatectomies. The reality is, from what we know and from the previous data, about 40 to 60 of those patients, percent of those patients will end up going back to the OR for splenectomy. So this is something that you would not want to pursue, at least personally, I wouldn't. And this data actually comes from our partial living donor pancreatectomy for the transplantation. So once we start early, around 7 o'clock in the morning, patient is being prepared, and after putting central lines, going to sleep, the surgery for pancreatectomy itself takes about 3 hours. However, it depends on the severity of the disease. The surgery can be started laparoscopically and then proceeded with open, or can be started with open right away. When the pancreas is being sent to the lab immediately after removal, we start the reconstruction. So again, as Dr. Bellin mentioned, we're doing 3 new connections. We're connecting the loop of bowel to the bile duct, loop of bowel to the stomach, and 2 loops of bowel together in the reconstruction of Y. So those 3 connections, obviously, although these are not immunosuppressed patients, there are still risks of leakages or strictures. So again, not totally complication-free procedure. Most of us like to take out the appendix at the same time of the operation. The reality, and it's a sad reality, that our patients, even if when their pancreas is removed and if they have a problem and come into emergency department, everybody else thinks that their pain is because they're chronically on pain medications. And we had episodes where patients, their appendicitis was missed, and patients were actually very sick until they were diagnosed appropriately. So this is just another unfortunate story about patients with a chronic pain. So while islets are being isolated, and we reconstruct during the reconstruction, we also put the feeding tube into the stomach. The feeding tube usually has 2 lumens. One lumen goes straight into the small intestine, and this is what we're going to use to feed patients post-operatively and deliver nutrition. The other lumen remains in the stomach, specifically to empty the stomach, and this way patients don't have to be with nasogastric tube forever. And it usually comes out a day after the surgery. Surgical drain is placed in the area of biliary anastomosis and at the site of the pancreas resection, specifically for monitoring bile leaks and also chyle leaks that can happen post-operatively. The anatomical considerations and severity of the disease have to be taken into considerations because, as I mentioned, pancreas is in a very bad location. It's really posterior in the abdomen, and it's laying really right on top of the big vessels. So actually with inflammation, and if you look, this is the look of the normal pancreas, and this is how the pancreas comes out from patients with chronic pancreatitis. All the inflammation sucks in all the blood vessels and everything around it. And it's actually very treacherous to try to take out the organ without damaging surrounding structures. And that's where, when we can, we do things laparoscopically, but we always tell the patients your safety is number one because you need to come out of the operating room alive with good outcome. So going a little bit back, after the islets arrive, we do infuse the islets into the portal vein most of the time, into the liver, unless there are evidence of the significant liver disease or increased portal pressures, because this way we can actually damage the portal system and the liver. So if there are elevated portal pressures, then we try to find another spot in the abdomen to infuse the islets. It's a peritoneal, somewhere in the intraperitoneal cavity. It can be a mental pouch or actually between the layers of the abdominal wall. The true magic, though, of the total pancreatectomy happens for islet isolation. So our pancreatitis is taken to the lab in the St. Paul campus, and it takes about 4 to 5 members, highly qualified members. As Dr. Freeman mentioned, Josh is one of them, to isolate the islets. It's first, initially, there's an enzymatic ingestion into the pancreas, and afterwards, the pancreas is being digested in the Ricordi chamber using, actually, it's mechanical and enzymatic digestion. It is important to establish a good islet yield, as you can see on this data published from Dr. Sutherland in 2012. I apologize. I'm not feeling actually well, so I hope I can finish. I apologize. The data that's been shown by Dr. Sutherland, that actually the number of the islets is associated with improved outcomes from the insulin in patients with insulin independence. Melina, is it okay if I'll sit down for a second? I really apologize, guys, but I am really getting very weak right now. No, I don't. I'll sit next to that.
Okay. Sounds good. All right. Well, we'll wrap up Dr. Kirchner's slides, and you're after this? Okay. I was going to say, I would probably just pick it up from here with these slides. I can. Sure. Yeah.
I'll comment.
Sure. So Dr. Kirchner will shout in if she has anything to add. So our islet lab is quite experienced, and so they've really adapted the process to each individual pancreas. And one of the key aspects to that is the very first stage of the islet isolation, they put an enzyme into the pancreas. And so they're changing the time of enzymatic exposure for each individual pancreas. They want to loosen up the islets from the surrounding exocrine digestive tissue, but without damaging the islets. We're still working on exactly at the end of the isolation, how do we assess those islets? What are the best measures of the quality of the islets? And then we talked a little bit before about when we infuse the islets, there are some issues around islet engraftment and islet injury at that time. So there's inflammation and hypoxia, and the islets have to develop a new vasculature in the liver. So all of that affects the long-term outcomes. So here, I think you are looking at just the islet isolation process itself, correct? And so we know that one of the steps, the very first step of our process is when we actually isolate the islets, that the islets are actually getting damaged through that process. And so the stress of actually pulling those islets out of the native pancreas tissue and the inflammation that's actually generated from the first steps of isolation can be very important. So it also can be very hard to release islets from the surrounding exocrine tissue, particularly if it's very fibrotic. See, I'm getting it here. And so they actually are working with different approaches to digest collagen and other scar tissue that's laid down there. So there may be some new enzymatic approaches in the future to autotransplantation. I'll skip through here very quickly, but we look at some of the markers we look at for quality of the islets that might be more important are actually the oxygen consumption ratio, or basically how healthy or how viable are the islets, because we can count islets and some of those might be dead islets, but we want to know what's actually living tissue there. And so then we have been looking at the best place to put islets. Now, as you heard from Dr. Kirchner, the conventional place is the liver. That's an easy place to access. We know they can engraft there. We know they function there. It's very well established in animal models. But it has some disadvantages. So you're in the portal vasculature where medications are processed and portal toxins. So there's a lot of work going on looking at, is there a better place to put islets, maybe in the peritoneum or the omentum? One of the disadvantages of the liver is that there is another hormone that comes from the islet cells called glucagon. And the glucagon is supposed to rise during hypoglycemia, and that may not happen as well in the liver, probably because the liver is our place where we store sugar as glycogen. So working also with other sites outside the liver to help restore that normal response to hypoglycemia. And then looking at some of those inflammatory processes that happen right after the infusion. So we call that the IBMIR process, or the instant blood-mediated inflammatory reaction. And right now, we put heparin in with the islets because part of that IBMIR reaction is that the bloodstream wants to form a clot around the islets, and we can minimize that with heparin. But that's what some of the other research studies, like the one that Sonia is in, is looking at whether there are other anti-inflammatory approaches we can use there. Takes about 3 months for the islets to revascularize in the liver. That's why I've always conventionally kept everyone on insulin for at least about 3 months after transplant, because islets can't produce insulin very well when they don't have enough oxygen supply. So in summary, there are multiple surgical options, and the diseased environment of the pancreas makes surgery difficult for our poor surgeons. And in the total pancreatectomy, it's not just the surgery piece, but also the islet isolation piece that is important. And I think I'll go through this just very quickly, if you don't mind, in terms of time. But right after surgery, our patients stay in the ICU. It depends a little bit on the side of the river. The adults are in the ICU for a shorter period of time because we're able to do insulin drip on the floor. We can't do that in pediatrics. But during that time in the ICU in the early post-operative period, they're watching for pain management, for glycemic control, starting feeding tube, giving heparin to prevent blood clots, watching for any clots in the liver, and starting on physical therapy. After discharge, our patients actually here stay around Minnesota if they're from somewhere else for a long time, a few weeks after surgery at least. And that's because we're seeing them quite often for labs, for nutritional management, for management of insulin, and weaning their pain medications. And eventually that feeding tube that we put in with the TPIAT surgery does come out. I don't know if you should celebrate with as much as that octopus has there, but it does come out. And hopefully they go back home and go on to a normal, healthy life. So, this is one of your patients, isn't it? So this is a young woman who had PRSS1 who, actually got married in 6 months after surgery. We don't highly recommend that though. So in terms of survival, patients with chronic pancreatitis, particularly adult patients with chronic pancreatitis, do have reduced survival compared to the normal population. So see, historically, and this incorporates patients who were very, very sick, early on in the program, about 80% survival at 10 years, or 85% survival at 10 years. And overall, we see about a third of patients who are insulin independent at any given time point, 1, 2, 3 years after surgery. But after that, we actually do see some waning of the islet function and a bit of a reduction in insulin independence rates. We see pain improvement in 85%, and for adults in particular, opioid weaning can be a real challenge. So about 60% are off opioids by 2 years, but the quality of life improvement is seen much, much earlier. So looking at timing of surgery, and this is probably data that came from a non-TPIT population, correct? So this is drainage surgery procedures looking at what predicts good outcomes. And earlier surgery, certainly in other types of surgery, has been associated with more complete pain relief. probably because that sensitization process is not as severe earlier in the course of disease. Patients who have had a very prolonged course and particularly have used chronic opiates for a long time, at least established in other forms of surgery, have a harder time with complete recovery. So thank you again. I think you've seen this picture from the team a few times. And thank you, Dr. Kirchner, for letting me pick up your slides. I think we got through it. All right. Thank you. So,
You have been disconnected from the meeting.